Hi, welcome to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, a reproductive endocrinology and fertility specialist, board certified in Canada and in the US. And we are going to be answering your questions tonight live. So if you have questions about anything related to infertility, ask and we will answer. I did look for a good topic for you guys tonight, an article to review like I normally do, but there actually wasn't anything interesting out. I've been scouring all 6 or so of the journals that we normally look at, but nothing has come out yet. So we'll have to wait till the next episode. And so tonight's going to be a bigger show as well because my wife abandoned me for another man, which is my son. So she's in Toronto helping him out. And so I got nowhere to go. And as well, we will not be back next week because we will be learning all things new about infertility at the European Society of Hormones and Reproductive Endocrinology Conference in Milan, Italy. So next week is going to be delayed until the following week after that. But we are ready to take your questions. And I know there were a bunch of questions that people asked. So I'm ready to go if you are. And I've got my very trusty friend Tarek off camera here. You got a whole bunch?
That's what I want to start with.
Okay.
Some people know how to ask questions.
All right.
Hi, T and Dr. V.
This again. Yeah.
Yeah. What are the E2 levels you aim for pre and post transfer? Thanks.
So we don't actually pay too much attention to the E2 levels pre and post transfer. As long as your lining is thick enough, it doesn't really matter. There was a study we reviewed a long time ago that showed that there was a lower limit threshold that you needed to be above, but there wasn't really an upper threshold. So as long as you have at least a minimal amount of estrogen, you're okay. We do look at the estrogen levels, but I don't focus on it particularly. Keep in mind, we use the letrozole protocol. And with the letrozole protocol, your estrogen levels are definitely lower. So we are looking at lower levels, generally speaking. Sometimes we have to actually give our patients a little bit of estrogen because the letrozole isn't enough to thicken their lining. And when that happens, we give them a little extra and it still works out. Yeah, so we don't pay too much attention. If I remember that study correctly, the minimum was 116 picomoles. I'm going back in my memory there, but we do have that study on fertility factor fiction. So it's up there and you can definitely take a look.
How many rounds of IUI with injectables do you recommend? What would be the starting dose for gonal?
How many rounds depends on your age. So there's a study we did review on the show called How Many is Too Many? And that is available on YouTube if you want to go and take a look at that. And basically, if you're over 38, 39, 3 rounds of IUI is the most you want to do. And if you're under that age, you can do up to 6. Beyond that, this was a large Chinese study that showed that the success rate was literally 0% above and beyond, 6 when you were younger and 3 when you were a bit older. Gonal F dose depends heavily on your age, your body mass index, your ovarian reserve. So for some women who are young, you might need 37.5 units or 50 units. And at the same time, if you're 30, which is still very young, and you have a low ovarian reserve, a low AMH, and maybe your body mass index is a little bit higher, you might need 150 to achieve the same result. So it all depends on multiple factors. There's no way to tell someone this is the dose that applies to everybody because it doesn't work that way.
Lifestyle recommendations for trying to conceive.
Oh, well, we come up with that one every week. So no smoking, no drinking, no drug use. Actually, somebody asked me about alcohol today, and they were confused about feedback from various other places and other doctors. So there is no amount of alcohol that is good for you trying to conceive, so you should get rid of it. So no marijuana, no smoking, no drugs, no alcohol. Lots of vitamins, in particular vitamin D, folic acid, and omega-3 fatty acids if you're female, and a whole bunch of antioxidants if you're male. A special diet with Mediterranean type diet, daily exercise, low stress as much as possible, and then have sex every day or every other day. Those are all good things to do. From the guy's perspective, ejaculate every day or every other day. Keep your testicles cold, take those vitamins we talked about, and avoid the smoking, drinking, drug use.
When will you start doing hysteroscopy surgeries in your office?
Hysteroscopic procedures. We have our first trial coming up in, I think, a week and a half. We're trialing the equipment, and then we have another one coming up, I think, a week or two after that, and then hopefully the third one right after that. But that rep has not called us back, and I have to get in touch with him again. So hopefully soon. Yeah, definitely when we get back, we have one trial, and then we have a couple of other ones we're trying to plan.
Would you recommend trying naturally post-cystectomy, myomectomy, or go straight
to IVF?
I'm assuming.
Go straight. Yeah, there's no reason after a cystectomy and myomectomy you have to go straight to IVF or to any fertility treatment. It depends on your age. It depends on how many kids you want. It depends on how strong your ovaries are. So that's not a question I could answer without further information, but it depends. There's a lot of factors that would go into it. No one would fault you for doing IVF. It's a very reasonable approach. But is it necessary? No, it's not necessary.
Got a pretty detailed question here.
That was really good dinner. Yeah,
Yeah,
that was good.
We upgraded that dinner.
We did upgrade that dinner.
My cousin has offered to donate her eggs.
Oh, cool.
She is 37 and has endometriosis. Can she still
No.
produce a good quality egg?
No.
Endo. I'm 41. She has also adenomyosis, and there's one more part to this question here. Also, can going through the process of getting eggs make her endo or adenomyosis worse?
So no one would advocate for using a 37-year-old egg donor. You're going to end up with about 2/3 of the embryos being genetically not normal. So she has to produce a lot of eggs to end up with getting even any that are genetically normal. The endo makes it a problem for egg quality. And then on top of that, yes, you will make her endo worse. So unfortunately, as much as I love it when family helps family for fertility, that is a suboptimal situation. We would not recommend it at all.
How do I mitigate any possible negative effects of DHEA on my health and egg quality?
Well, the only negative effects are maybe acne and hair growth. And that's pretty short-lived and it's not permanent. So we really don't do anything to mitigate. The only other element is that it could make you gain weight. So you want to make sure you're not gaining too much weight. And that's easy, diet and exercise, which will also actually potentially minimize the acne and hair growth. So take care of your skin, watch out for hair growth. It's going to be pretty minimal. It depends on how long you're on the DHEA and what dose, but we rarely have any problems where we have to tell people to take mitigating measures.
Another fantastic question.
Okay.
Hi, Dr. BNT. Are there any studies on the use of antihistamine protocols?
Yeah, I looked this up a long time ago. I didn't find anything that was convincing by any means. I'm happy to look it up again. We could probably even do it now. But yeah, nothing that I've seen that really kind of caught my eye and made me say, hey, this looks like it's a really good study or an important one for us to consider. So no, as of now, nothing that I've seen that looks particularly important. Let's go. What's that?
Do you want to say another question?
Yeah, sure. I'll look it up while we're waiting. But
Dr. Victory booked their first appointment with you, and we are so excited.
oh, awesome.
Actually mentioned there are initial tests needed to be done. Which ones are those so we can get the ball rolling?
Well, we give those all to you after you talk to me because I need to know what's going on with you before I can customize your testing. In general, we're going to look at basic blood work, cholesterol, CBC, sugar, things like that, vitamin levels for both you and your partner. We're going to look at doing a sperm analysis for your partner, infectious disease testing. And then for the ladies, we normally will monitor them for a month with hormones, ultrasounds, and a saline infusion, so on a histogram to look at the uterus and the tubes and so on. So that's kind of the general gist, but it very much depends. For patients with recurrent failures, recurrent implantation failures, previous cycles, sometimes if there's a history that's suggestive of endo or adeno, things can change and the tests that we order can change. So it's not like a one size fits all.
SMBC, early 40s, where to find donor embryos?
Single
Well,
mother, I don't know, SMBC. In any event, where to find donor embryos? So there are two venues for you to find donor embryos. One is to contact individual, actually, I guess there's three. One is to contact individual centers and ask them about their embryo donation program and see what you can find. Two, there are forums where people will offer their embryos. So if you get online and you get very active and communicate with people and say, hey, I'm looking for donor embryos. I know people that have successfully identified embryos that way. And then the other way is that there are agencies which will facilitate getting you donor embryos, but they are extraordinarily expensive, like crazy expensive. So I don't use those agencies. We don't work with those agencies, but you can contact centers directly and they can help you, or go online and find the forums. I looked up antihistamine and IVF and there is nothing. So I'll try in vitro fertilization. Go ahead.
What to do for migraines during IVF and pregnancy?
Maxiran. So it's a secret of ours that we use it all the time. You can use Maxiran to very good effect to help with headaches when you're pregnant. So a 10 milligram dose of Maxiran very frequently will get rid of people's headaches while they're pregnant. And that's what we use all the time in obstetrical triage.
Does HIIT training decrease ability to conceive?
No, the opposite. HIIT training will increase your ability to conceive if you're heavy. If you're already in great shape, it's probably not a great idea because it does make you burn a lot of fat, and you need some fat in order to have your ovaries function properly.
Is there a difference in efficacy between Ageastin and Lupron Depot for FET prep with endo?
A what?
Efficacy between Ageastin, Agyestin.
I've never heard of that drug before, so it must be from Europe. But if it's another form of a GnRH agonist, there's not going to be a difference. Lupron is just one form of a GnRH agonist.
TTC times 10 months.
Okay.
1 MC. Recently had COVID. Noticing my cycle is off now. Late. Any suggestions?
It usually typically only lasts 1 month. So just wait and it'll go back to normal. There's nothing to do. So COVID can delay your period. The average in a published study, I think it was published in the Lancet, may have been the New England Journal, was just that it's a 1 month delay. So that's not a big deal. It's nothing to worry about. Just wait and it'll come right back to you.
We had one of our viewers help us with SMBC, single mother by choice.
Thank you. Single mother by choice. You know what? I should have known that. Thank you for pointing that out. That's very helpful.
The same viewer, I guess, is progesterone.
So the question was what again? It was Lupron or progesterone?
Yeah, that's the question. Lupron Depot progesterone.
So what's the question?
The question is, if I can find it, because there are so many. Here, is there a difference in efficacy between Ageastin and Lupron Depot for FET prep with endo?
Yes. Lupron is going to be much stronger and suppress your estrogen levels much better than progestin will. So you should definitely take Lupron plus letrozole. So Lupron alone before an FET actually has been shown not to improve success, but Lupron with letrozole before an FET has been shown to be better for people with unexplained failures. And they assumed in that study that the majority were because of endo. So you should take Lupron with letrozole to improve your outcome.
I think there's a pharmacist on the show. The Agacin is the name for norethindrone.
Yeah, that's a type of progesterone. Yeah.
Now you know everything.
There you go. Now I know. Yeah.
All right.
There is nothing on histamines and IVF. I did a search for you. There's nothing. So there's still no data on histamines and IVF. No one's done any kind of study.
How many rounds of IVF do you recommend for someone in their early 30s with unexplained, I guess, infertility?
So it depends on the number of embryos that you produce. So if you're in your early 30s, you can anticipate that about half of your embryos will be genetically abnormal, not normal, maybe a little bit less. So for you to get pregnant, you need to produce 3 genetically normal embryos to get a 95% chance, 95.2% chance of pregnancy requires 3 genetically normal embryos. So in order for you to get those 3 genetically normal embryos, you got to see how many overall you need. So in theory, if you're kind of 50-50, you need probably 6 blastocysts. In many cases, in your early 30s, you should be able to achieve that in one go. But it depends on the strength of your ovaries, the quality of your lab, how they fertilize your eggs, and so on. So you're aiming for 3 genetically normal embryos. You need to know the number of abnormal embryos based on your age, and then you need to calculate how many eggs you'll make. Our video on YouTube, our most watched video, which I suspect by now is up to 72,000, is exactly that. It actually tells you how to calculate how many cycles you need. So it's called Embryo Math, and you just have to watch that, and it'll explain to you how you calculate exactly the number of IVF cycles you need. Usually in your early 30s, 1 cycle should be enough, maximum 2. And if it wasn't working after 2, I'd want to know why, because something is clearly not right.
Ciao, Dr. VNT.
Ciao. Hey, I'm headed to Italy. I love it.
As a U.S. patient coming to you for transfer,
yeah.
How do I set up for ultrasound and other prep work out of the U.S. to limit trips to Canada? Grazie, buon viaggio in Italia.
Grazie.
Grazie.
Grazie, Viago.
Grazie, buono.
Oh, grazie, buono. So thank you, mille grazie. Yeah, you just go to any center near you and they can do the monitoring and they'll just fax it to us. So it's very simple. You just hook up with any fertility center near you that can do blood work and ultrasound when we need them to. We just send them the request and then they set it up and follow through with us. And they fax us the results. We enter it into your chart here and we have the info we need.
Your Italian sounded pretty good, to be honest.
Mille grazie. Yeah, well, I hope so. I gotta go there in a couple of days.
Hi, Dr. V. Approximately how long and how much does it cost to do immune intralipid therapy for that FET?
Okay, so our costs are really low, or at least in my opinion, they're really low. So our first treatment is $250. You do that 5 to 10 days before your embryo transfer, and then it's $200 every time after that. So it's not particularly expensive. You get one at your first positive beta, and then at the 6-week mark, some people stop there, other people continue every 6 weeks. So it depends on how many more you do.
Failed my first FET.
Sorry.
I did the standard stuff in addition to Neupogen, ASA, Lovenox. We are using untested DEs, 4AA. I'm 49. What could have been the problem? What would you suggest we do next cycle?
Well, that's a great question. So first of all, I need to know a lot about you, your health, your habits, your body mass index. I need to know about your vitamins. I need to know about what supplements you were on. I need to know your protocol and then your general health. So it's not something I can kind of suggest without a consult. Those are the things we specialize in. So just contact info@drvictory.com. I'll be happy to go through it with you and figure it out, but I need to know exactly what you are all about in order to figure out what's right for you. There's no like cookie cutter approach with us. So I never say, hey, everybody should go do this, because it doesn't work that way. I will say kind of in general, most programs use way too much estrogen and that can be detrimental. And then they don't use progesterone, both vaginal and in oil. And I believe that's detrimental. You need both, and you need your levels checked. And that's really important when age is a bit of a factor as well. I would also want to know why you're on Lovenox and Neupogen. Like, that's not something we do automatically for everybody. So those are important things for us to figure out. And then lots of detail about your uterus.
What do you think about swimming after an FET or before if you're trying to avoid infections?
You're not going to get an infection from swimming. There's so much chlorine in those pools, it's actually quite difficult to get an infection. So I'm not worried about getting an infection. I would say before an FET, it would be great. If you're talking about after an FET, I mean, a day or two after, no problem. I wouldn't do it immediately.
If I had an endometrial biopsy today,
Yeah.
can I do a FET natural stimulated in 18 days? Or what's the recommended? What's the disadvantages of transferring so close?
So the studies that have looked at endometrial biopsy have, generally speaking, looked at doing it in the luteal phase of the preceding cycle. So basically from day 14 to 28 of your preceding cycle, most people would do it around day 21 to 23. And then into your next cycle, you do your embryo transfer. So you're kind of close to that with the 18 days thing. It sounds like they kind of did yours in the middle of your period. I don't know what benefit that has. The truth is, endometrial biopsy is literally the most controversial thing in fertility. They're still publishing studies on it constantly where one group says it works and the other group says it doesn't. Nobody knows is the reality. We just don't have the right kind of data to be able to answer it. And they've done good trials, randomized controlled trials, but they're just complicated. They're not always, extremely well done. The kind of protocol is good, but the patient criteria may not always be excellent. So yeah, nobody knows if the scratch works. I think nowadays, most people don't really believe in it. I have not done one to help somebody get pregnant in probably about 7 or 8 years. It's been a very long time since I did an intentional scratch. Yeah.
What is the success rate for embryo donor eggs, donor age 25 years old?
With us, it would be extraordinarily high. We very, very, very rarely have failures, assuming everything else is okay. I can't speak to other centers. I can only tell you about us, but I would say in general, most places do very well. Donor selection is very key. You got to pick good donors. We work with a lot of great agencies and they will only use great donors, and they know that I'm very picky, so they only introduce great donors. So that's been very helpful for us. You have to have a very good lab. They have to do a good job. And then you need to optimize sperm quality. And then, of course, you have to optimize the recipient. So weight, diet, exercise, keeping your stress levels down. All of those things are really, really important.
Hi, Dr. B. My family physician just sent a referral yesterday to you, Sarnia office.
Okay.
Do you know how long it'll take to get back to me and what will be my next step after being accepted? I'm so excited.
Well, I'm excited to see you. So we normally put those consults in, and then either myself or Dr. Mayrand or our nurse practitioner, Kasha, will jump in and get the initial history. I do all the follow-ups, but they often will get the initial history to get things moving a little bit faster. So typically like about 2-3 months. We're a little bit behind in Sarnia, but I think we'll be caught up very soon. So I would think within about 2 months, we should be able to reach out to you.
Why do some follicles not have eggs? Had 11, Dr. retrieved 7, has happened for 2 rounds.
So that's a really good question. There are many people that believe that it's actually just a failure to get the egg out. It does happen. It doesn't matter how good a fertility specialist you are or how good you are at egg retrieval. Sometimes the egg just doesn't come out. So there are some tricks that you can use to improve that. When the needle goes in, you can kind of twist it a little bit to make sure you empty the whole follicle. You can kind of pull back as the follicle collapses to make sure you're constantly keeping the suction on. Having a good suction device and keeping it at the right level is really important. And then the other thing that's really critical is what we do, which is flushing. So if we have a low number of eggs, 10, 11, that kind of thing or less, we actually flush fluid back into the follicle if we don't get an egg. So I'll do the draw thing, I guess, because you love the draw.
Yeah.
Tarek loves when I draw, guys. So I'm going to draw for Tarek.
I find it somewhat soothing.
So much. You're so goofy.
Hold on, one sec. I have to get it. You know, people find drawing things a soothing thing. Just so you know, I'm not making this up.
No?
No.
Okay, I believe you. Where's notes? Oh, there it is. Okay, so I need to do that. Yep. Okay, here we go. Okay, so no, not yet. Why is this not rotating? Oh, there we go. I will connect. Screen mirror, there you are. Okay, so flushing is really cool. I'll kind of draw it for you so you understand. Okay, so I'll need a slightly smaller than usual marker. So if this is your egg, your needle goes into the egg, and coming off of the needle is a tube that goes to the test tube and another tube that you actually connect to a syringe. So what happens is you go into the follicle, you drain all of the fluid, and as the fluid drains, it should be going, I guess I'll use blue for the fluid, it should be going this way and into the tube. So then you hand the tube off to the lab checks it and says there's no egg. So then what you do is you flush fluid in this way, it goes back into the follicle, re-expands the follicle, and once you've re-expanded the follicle, you can then go ahead and drain again, drawing the fluid down, and you keep doing that until you actually get the egg. So that's the way we do that. So you can flush, and that's flushing, and it helps extract all of the eggs.
I just asked our YouTube video watchers if they enjoy your artwork, and it's overwhelming, yes.
Well, that's great.
Yeah. Okay. You've addressed ablation and excision being the same for endosurgery, but are there studies done on this? I saw an article saying ablation doesn't get to the root of the endo.
Yeah, there is an article, and they directly compared excision versus ablation, and it was a 1-point difference in pain. So that is not clinically significant. It was like a 98 versus a 99. It has no relevance whatsoever. There is no difference. There is absolutely no difference between ablation and excision. It's the same thing. Now, that applies to superficial endo. If you have deep infiltrating endo, which we call DHEA, that's a different story. You do need to go in there and dig it out. So that requires excision. But if you just have superficial endo, there is no difference. Like a stage 1 endo case, there is absolutely no difference between ablation and excision. And I can do both. You don't have to torture patients or risk them by digging into the tissues to get it out. It's just not invading enough for it to make a difference. We're not still sharing, are we?
No.
Okay.
Do you have another art?
No, I was wondering. No, I'm good.
Started the second round of letrozole, and I'm now on cycle day 14 with no positive LH test yet.
Okay.
I'm recovering from COVID. Can being sick interfere with medications such as letrozole?
Yeah, for sure. So COVID can give you gastrointestinal upset, which can alter how you respond to the meds. And then as well, not just how you respond, but how you absorb it and then respond. And also COVID can cause a lot of systemic inflammation, which can then alter your immune responsiveness, which is why people get delayed periods. So I wouldn't have even tried that close to a COVID infection. Wait at least a month.
Got a controversial question here for you.
Controversial. Hey, why not? Let's do some controversy.
This could be a YouTube video.
We should play some Prince controversy.
This will be a whole thing. Hi, Dr. V. What are your thoughts on Roe versus Wade, if you care to share? If you care to share.
I believe all people should have their viewpoints respected. And that is all I am going to say about that topic. I don't feel that it is my job as a fertility specialist to get into the controversy surrounding what is right and wrong around abortion. So I'm going to stay well clear of that. I thought about talking about it on social media after I heard about it. And I really genuinely feel that there are too many heated viewpoints on all sides for me to want to wade into that and get involved in, saying that one viewpoint is right or another is right. I have my own personal beliefs. I am very strong in my beliefs, and I'm going to keep those personal. So my job is to take care of you. Regardless of what I believe in, I take care of people as they would want to be taken care of. And so that applies to every aspect of what I do. And I don't introduce anything I believe in into how I take care of anybody else. And I think that's a big part of respecting people. And so whether you're pro-life or you're pro-choice or you're pro-birth or whatever term they're using now, I believe everybody should have their views and their rights respected. So that's all I'm going to say about it.
There you go.
Keep myself out of trouble.
I think you did good.
Yeah.
Got COVID and about less than 2 weeks before my FET. Should I cancel instead?
Yes, cancel. Now, I'm saying that because I believe it inflames your immune system and I think it takes a toll. But they have done a study which showed it didn't make a difference. So the scientific part of me is supposed to tell you it doesn't matter. But the rational part of me says it's impossible that it not matter. So I just don't believe that data. So I would wait. And look, waiting a month is not going to make a difference, or 6 weeks. So I would just wait, and then you're clear, and then you don't need to worry about it. Because if it works, you're going to say hallelujah. And if it doesn't work, you're forever going to kick yourself for why you used up an embryo when you could have waited 2 months and you would have gotten a better result.
Hi, Dr. Victory. I just tried my first IUI in Sarnia.
Oh, great.
You are all wonderful.
Oh, thank you. You know what? I love both my teams, Windsor and Sarnia, and our new clinic that hopefully will be opening soon. So thank you for saying that. They are wonderful people. And welcome to Haley. I don't know if she's watching the show, but Haley is our newest nurse in Sarnia. So welcome to the club. VRC is massively growing. So we have just hired another nurse for our Windsor site, and we have hired a new coordinator for our Windsor site, and we are also hiring another nurse shortly. So if you're a fertility nurse and you want to work for VRC, please send us your resume, because we are looking for some great fertility nurses, and we need one for helping out with our autologous IVF program. So let us know.
100%.
Never thought of advertising here,
That's a really good platform.
That was a great platform for us to, yeah.
A lot of people here.
Yeah. Nurses, we need you. So please apply. Send your resume to, send them to Mara at drvictory.com.
She's not like that.
She's going to kill me. I love you, Mara. Yeah.
Hi, Dr. V&T.
V&T.
You mentioned a few times baby aspirin is helpful to embryo transfer.
Yeah.
When should I start taking it, and when should I stop? What's the dose and any specific brand you would recommend?
Brand doesn't matter as long as it's enteric coated, so it protects your stomach. 81 milligrams is the dose. And we started pretty much when we start your stimulation for your FET, because it actually will help you develop your lining. So that's the best time to start it. So yeah, 81 milligrams. Start when you start your stim, and get enteric coated. The brand doesn't matter. Whatever's cheap.
Hi, Dr. V&T. I'm 7 weeks, 2 days.
Hey, congratulations.
My clinic put me on Intralipids before transferring weekly for 12 weeks.
Yeah.
Should this be continued to 12 weeks, or can I stop sooner? I don't know.
Yeah. Intralipids is a very reasonable thing to use. There are studies that showed that it lasts up to, or sorry, that ran their studies up to 12 weeks. And there were other studies that ran their studies up to 34, 36 weeks. Nobody knows. And so in order to make sure that we offer you the best care we can, we always have a lengthy discussion with you about it and figure out what you want to do. So someone just rang our door at 8:30 at night. It was one of our nurses or was somebody else? Oh, okay, great.
A lot of people here, you just said.
Yeah.
Doing my best, you know. Yeah. Instagram.
We had a lot of Instagram questions. There's a lot, yeah.
Treatments for a thin lining if estrogen supplement isn't working.
PRP, Neupogen, vitamin C, D, and E, baby aspirin, Viagra, human growth hormone, GM-CSF, which is Neupogen. I think that's all of the ones. L-arginine is supposed to help a little bit. Supposedly, I've never tried that one before. Pentoxifylline can also help. Vaginal estrogen, transdermal estrogen, all of those can be helpful. Hysteroscopy if you're worried or testing for infections. Any and all of those are reasonable approaches. Stimulation with gonadotropins like FSH, so gonal F, Menopur, that stuff, that can also help as well.
I'm interested in how you're going to tackle this question.
Oh, okay. I love it when you prep me with the challenge.
Yeah,
That's good.
yeah.
Okay, yeah.
How do you
We need to like put me in a dark room electronically, you know, and I could, yeah. How do I?
Because I think that the answers could be common. You have a lot of play with this.
Okay.
How do you know you have endometriosis? Good question, valid question.
Okay.
Great answer you'll give here. Second part of the question, it could be a little rough here.
As long as it doesn't say Roe versus Wade.
No. I suspect I do, but my doctor won't check.
Oh, okay. Yeah. So how do you suspect? So it's called the 3Ds. Do you have dyspareunia, which is pain with intercourse, dysmenorrhea, which is pain with your period or painful bleeding, and deep pelvic pain, which is just pain deep inside. So if you have any of those, and frequently heavy periods as well, or bladder and bowel symptoms with pain, it's possible you have endometriosis. You can sometimes detect it on physical exam because you'll feel nodules in certain parts at the top of the vagina and behind the uterus. If you're a very good gynecologist, it's not an easy thing to do, but sometimes you can detect them. And that will help as well. And then you have to test with laparoscopy by looking inside people. Occasionally, depending on how bad the endo is, you can detect it with an MRI or even an ultrasound if you have cysts of endometriosis, but little spots of endo you cannot detect with anything. The BCL6 test is useless, so don't do Receptiva or BCL6 testing. And as far as your physician is concerned, it's a really sad fact that a huge number of women go undiagnosed for years with endometriosis before their physicians actually listen to them. I'm kind of the opposite. I'm actually the guy that tells people to get surgery to see if they have endo, because I don't want you suffering for 3 years until I figure out that you actually have endo. So for us, if I think you have endo, I'll tell you should get checked. So I actually spoke to a physician today who I think has endo, and I told her you should really have surgery to evaluate this because that's important as part of your journey. So yeah, I'm a believer in checking for it. You really need to find a physician that listens. If your physician is not willing to listen, then I would happily question their knowledge and their motivations because there is no reason to not listen to a patient. So, you know, that it just doesn't make sense not to listen to someone. And hey, you know, for whatever it's worth, I 100% respect women's intuition. So my wife, my mom, I think they're both godsends, and my office staff as well. So, you know what? I listen to the women around me. Why wouldn't any doctor listen to his patients? It just doesn't make sense.
told you like that.
I did like that one. Yeah, not a challenge, but it was a good question
Yes,
for
good
sure.
question.
Yeah.
A question we've never had before.
Oh, hey, hit me. I'm ready.
What kind of food
Don't
I
actually
should
hit me.
eat after embryo transfer, warm or cold? I have a transfer tomorrow.
So you know what? The person to ask that from is a traditional Chinese medicine specialist, because they deal much more with yin and yang and what is, called cold and hot. I don't think it makes any difference. Whatever satisfies you. You just don't want to shock your system. So, maybe just have like a room temperature food. You don't want to, eat or drink something super cold, and you don't want to have something blazing hot. Just moderation. So I don't know, have a sandwich or, something like that. Whatever you feel like eating is fine, though. There's no restriction. People are always, fascinated and focused on what diet works best and what meal works best and what kind of food to eat and so on. Yes, there are slight, and I do emphasize slight, differences based on diets. And there's no question that the Mediterranean diet has been shown to be advantageous. However, if diet made all the difference in the world, there would be cultures that would have way more children than other cultures. And, that's just simply not the case. I mean, birth rate wise, it's pretty universal. So I don't think your diet makes a big difference.
Day 6 FET, non-double, but rising HCG. Saw HB at 6 weeks, MM at 10 weeks. Do different next time?
Okay, so I think what I caught from that was somebody had a day 6 embryo transfer, had an initially slow rising beta that was not doubling, did see a heartbeat, but then subsequently had a miscarriage. So I hope I got that right. So yeah, I mean, you need to find out why you miscarried. You can't always figure it out, but there are a lot of factors that can go into miscarriage. So I would need to know specifically some more details about you, your age, your partner's status, his sperm quality, DNA fragmentation, your health habits, his health habits, body mass index, the shape of your uterus. Are there polyps? Are there fibroids? What kind of embryo was it? Was it natural? Was it artificial? Methodologies like we use, IVF, IUI. There's a lot that goes into it. It's not just hey, I would do this differently next time. You need to contact one of us and go through it. Now, if it was just your first ever miscarriage and you're a young, healthy person, you don't need to do anything. Keep in mind that 1 in 6 pregnancies will end up in miscarriage. So 1 in 4 women will have one. So it is a very common event. It's a horrible event. It's emotionally taxing and draining. It's psychologically devastating, but it's common. And because it's common, it can happen to anybody at any time, even when there's absolutely nothing wrong with you or your partner. So we don't do anything normally if it was just one time. If you miscarried a genetically normal embryo that was implanted after a heartbeat was seen, that would make me nervous. I would want more testing. But if it was just, hey, I got pregnant and I had a miscarriage, that's a different story.
And thank you for what you were doing.
Oh, you're welcome. My pleasure.
What is your opinion on minimal stimulation IVF for those 42 and over?
Okay, so you need to watch Embryo Math. If you look at the data, there is no question that the data supports the concept that mini stim and normal stim end up giving you the same live birth rate. You do get more eggs and embryos with a full stim, but the live birth rate ends up being the same. Now, you may require more cycles with a mini stim, but you can end up getting the same success rate ultimately as you would with a full stim. In my opinion, that is a very simple thing to say when everything's insured and you can do 100 cycles of IVF. But when you don't have insurance and you're paying for it privately, it is a wildly different scenario. And in those situations, I definitely recommend to people that more eggs are better. The more eggs you have, the better you're going to do. Now, if your ovaries are really weak and you're only making 3 eggs, whether you take a dose of 150 combined of whatever meds you're taking, or you take a dose of 450, you're still only going to make 3 eggs. So it's pointless to take 450. It literally is not helpful at all. But if you can make 12 eggs or 15 eggs and you're 42, and you take a low dose in order to just get 3 or 4 eggs, that to me is a mistake. You should be going for the 12 so that we can maximize the number of embryos we make, try and get some that are normal, and then move forward from there. Good question. That's a really good question. We haven't gotten asked one like that for a long
I got a
time.
bunch of new questions today. This is my official conclusion.
All right.
New people here.
New peeps.
New peeps.
Excellent. Tell all your friends.
Yeah. All right.
Tell all your friends. And hit the like button, and make sure you subscribe to our YouTube channel and our Instagram and our Facebook. Follow us.
This might be a drawing question.
A drawing question. All right, I'm ready.
What can be done for a left-sided hematosalpinx measuring up to 0.8 centimeters in diameter? Does this require surgical removal for fertility? Can it become worse if left untreated?
So a hematosalpinx is very rare. I suspect you actually mean a hydrosalpinx, which is when there's fluid in the fallopian tube. But even if it is a hematosalpinx, it needs to be removed for sure. You have to take that tube out. It's a 50% reduction in your IVF success rate. So it has to be removed.
No drawing necessary.
No drawing necessary. I avoided the draw.
Yep. Hey, Dr. V. My doctor insisted that for a natural cycle transfer for people ovulate regularly, no need both PIO and vaginal suppositories.
Mm-hmm.
He suggested vaginal only.
Yeah.
What are your thoughts?
I disagree. So there are lots of studies which have supported the fact that PIO is better than vaginal. And then there's at least 1 or 2 studies that have shown that PIO with vaginal is better than PIO or vaginal. So I'm just going to say I disagree. We actually reviewed that on the show not that long ago on the 3 different types of progesterone. And it's in that study, and it shows that the combo is better than either one alone. But PIO is the best approach. Vaginal alone is the weakest approach to succeeding for fertility.
What does a sonal histogram check before FET baby?
It checks the shape of your uterus. It checks the inside and the outside of your uterus for its shape. You'll know if your cervix is really tight. You'll know if there's any polyps or fibroids or scarring. You'll know if your tubes are open. You'll get a look at your ovaries. You'll also see if there's any hydrosalpinx or any abnormalities around the tubes. All of those things are available and evident.
Heavy question.
Heavy. Like it's weighing you down heavy?
There's a lot in this.
Okay, fire away.
Doctor.
Yes.
After how many cycles of IVF would you recommend to stop and use donor eggs?
Great question. It's program specific. So depending on where you're working with, I think that answer genuinely depends, because some programs have a higher success rate. And so in their program, if you failed after, let's say, 2 or 3 times, they might tell you to switch to donor. And in other programs with a lower success rate, they may say it's reasonable to do it 4 or 5 times. In my mind, personally, regardless of your age, if you've tried 2 or 3 times, you need to have the discussion. So if you're a young woman and you've tried several times, or if you're an older woman and you've tried several times, you have to at least have the discussion of the benefits and the risks of doing IVF with a donor egg cycle.
And Dr. Victory, I just had my first IUI in Sarnia.
Okay.
You're all wonderful. I did Lupron Flare, Menopur, Gonal 300. I was a poor responder, and she puts in brackets, yay me. Should we try IUI again, or should we just go to IVF? I'm up in age 38, but did not lose the weight you suggested.
So IVF is going to give you a better chance, but it will be hampered by factors like diminished ovarian reserve and or weight. I am always very hesitant to do IVF in people where body mass index is a concern, because the results are drastically reduced. And so you're spending a lot of money on something where I cannot get you the normal success rate. So for example, If your body mass index is over 40, your chances of success are likely reduced by about 80%. So take an average 35-year-old, our program would have probably about an 80% chance with one cycle of IVF, maybe even a little bit higher. Not knock 80% down by 80%, you just gave yourself a 16% chance of success. So does that make sense to me? No, of course not. So depending on your age, losing the weight can be critical. And then making sure your ovaries are functioning properly is also critical. So have the discussion with me. We will help you out. There's always options, but I'm very reluctant to tell people where they're struggling with their weight to jump into IVF unless age is a crushing kind of issue. 38 is the cutoff, so it does make it kind of tough. At 38, you're supposed to skip losing weight and go straight into IVF because of concerns with regards to the function of your ovaries. And we actually reviewed that on the show years ago, probably 2 years ago. But at the same time, it is really important to try and get your weight and your health optimized, or else the IVF it's drastically reduced. So have a talk with us and let's see what we can do to help you.
My last pregnancy ended because the baby had excision
Anencephaly.
Anencephaly.
Yep.
Detected at 12 weeks ultrasound.
Sure.
What could have caused this? Older age, high BMI, nutrition?
Yeah, so primarily it's a lack of folic acid. There is an association with high BMI and anencephaly, unfortunately. So it could be that as well. But it's primarily low folic acid for anencephaly. So make sure your folic acid levels are appropriate. If you're a smoker, please don't be. But smokers need double the amount of folic acid. So that can be a factor as well.
What can be done about deep infiltrative endometriosis in uterine ligaments?
Remove it. So you can operate, dig out that part of the ligament. So that's easy. Actually, it's not a complicated thing to do.
Fibroid removed today vaginally. It was about 5 millimeters. How long should I wait for a frozen embryo transfer?
A 5 millimeter fibroid, arguably you could have your embryo transfer done in, anytime relatively quick, like next month would be fine.
What is the success rate for an embryo donor egg, donor age 25 years old?
That person asked us that earlier.
Okay.
Donor egg embryos are extremely potent under normal circumstances. And so again, depending on which program you're using, like, whether it's VRC or XYZ or, ABC, you'll get different results. I will tell you that in our program, we almost never fail with donor egg. It's extremely rare. So depending on where you're going and what their success rates are, you can get different results. We got to tell that guy on the motorcycle to quit it out there. Yeah.
A 32-year-old, what do you think the rate of normal embryo have endo and poor egg quality, and does that matter?
At 32, depending on whose data you look at, you're probably looking at somewhere between like 20 to 30, 35% chance of aneuploidy, genetically abnormal embryo.
When looking for a surrogate, does it matter if they have had a previous C-section?
It can matter. It depends on how strong the wound healed and how well it healed. If the C-section has that isthmoseal divot, it can make it harder for them to get pregnant again and pose risks for the pregnancy in terms of safety. So it can depend. Plus, if they've had one C-section or two C-sections, it's not a huge deal. If they've had more than three, the placenta can either be previa or it can get stuck. If you're paying for the services of a surrogate, which everybody does, that can be devastatingly expensive. So it depends on the number of cesareans, what their uterus looks like. Many of those factors are critical.
Hi, T and Dr. V.
Oh, T first. One of
those.
You're moving on up.
Although the question is...
It's pure me.
But I appreciate you know, the shout out. Third retrieval, prep with meds. Day 2 started. 10 milligrams letrozole, gone left 300, Menopur 150 with 5 follicles. Today, day 5, 1 mature follicle, started cetrotide, double dose, 0.25 by 2. Would you do something different? 41 years old, no other issues, low AMH.
I use a microdose flare for our patients with low AMHs and a duostim frequently as well. So I would probably do that differently. You don't need that high a dose. It works in some cases, so I do use it in certain instances, but more and more my lab director is telling me to back off of the high doses because she's seeing egg quality changes. So we're probably going to be using lower doses moving forwards. And I guess the big question is, when you say mature follicle, how mature was it when they're starting your cetrotide? Because you do have some wiggle room. And if you start the cetrotide too early, day 5 would be considered kind of early. You may end up over suppressing the remainder of the eggs and they may not develop properly.
When do you do PRP in the IVF process to try and thicken the uterine lining? Thanks, Dr. B&T.
So people talk about doing it 48 hours before transfer, but the reality is that you frequently see the effect of PRP on the lining thickness the next month. So I would probably do it, throughout the month and try and get that benefit the following month.
Can you do an endometrial biopsy to rule out endometritis and FET in the same cycle?
You could, but you'd be crazy to do that. It's not safe because you're disrupting the endometrium. And if you're lucky, you'll get your answer back in time. But now you've taken a whole bunch of meds and prep and gotten ready. And then if they tell you you've got endometritis, you got to stop. So we don't recommend doing that.
How soon after a polyp removal can you do a FET?
Next month.
I had an endometrial biopsy today. Would it be safe to do a frozen transfer 18 days from today?
That person asked that too.
Multiple aspects.
Yeah. We already answered that one.
I miscarried at 9 weeks after trying for a year. It was out of the blue. What test I should do?
Yeah, I think I answered that earlier. There's a lot of tests, but it depends on whether or not it was your first miscarriage or you've had multiple miscarriages. So it really depends on a lot of factors.
When are Emma, ERA, and ALICE needed? How to know if all 3 tests are needed?
So the ERA test is bogus, so it's never needed. iGenomics knew it was such a bogus test that they sold the ERA test to somebody else. So don't do the ERA test. Emma and ALICE are usable and they're reasonable tests. So, I mean, it's not really indicated unless you have a very low number of embryos or you've had previous failures or miscarriages. So that's when we're doing it. But aside from that, very rarely.
What success rates for natural IVF male factor? What supplement should we take before fresh or frozen transfer?
Oh boy. Natural IVF success rates, very highly dependent on your age and ovarian function and the sperm quality and so on. Probably on the low end, 20%. On the highest would probably be about 40 or 50. And that would be rare to get a 50, but we were for a long time running at about 40%. In terms of supplements, vitamin D, omega-3, melatonin, aspirin, the fish oils, your prenatal, and that's everything.
Can your lining be too thick for PT?
Yeah.
Natural cycle protocol, and my lining is 14 millimeters on day 17, 1 day post ovulation.
Yeah, so I asked this question in Chicago at the conference I was at 2 weeks ago, and a lot of people said no. I disagree. I actually think a 14 would be too thick, so we tend to back off when it's that thick. We like an upper limit of about 12, 11, 12. And that's with me pushing my luck with my lab director because she wants it even thinner than that.
Hey, T, get a mic. Yeah.
Yeah, we're going to need to mic you. Can we mic two people at the same time?
Technically. Yeah. No. We just gotta get more gear.
More gear.
More
You,
gear.
you better get it. You better get a
We're
mic.
gonna have more cameras then. Every angle. Rocky Victor.
And then just keep switching between them.
Switch on the
Oh,
walls.
great. Go shopping, buddy.
All right. I'll go. Last question, 901.
Yep.
Can you discuss the results of Receptiva and what the numbers themselves mean? I've been told 1.5 to 4 is all the same positive, but the study on their website seems to imply a higher number equals poor outcome.
So Receptiva DX is a test that measures this oncogene protein product called BCL6, and it is useless. So it's been proven to be useless. They just published another study demonstrating it's useless. Don't waste your money on it. Don't follow it. It doesn't mean anything. It's not helpful. It's a useless test. So don't follow BCL6. Don't do Receptiva. Don't pay attention to the numbers. It's meaningless. If you think you have endo, which is the main reason to do the BCL6, you need laparoscopy to figure it out. Plain and simple.
One more. That's a good question.
Yeah.
Well, I think I know the answer to it, but go ahead. If I have an allergic reaction to the PIO, what are solutions?
Stop. So allergic reactions to PIO is not a good thing. And some people get these like big pink welts on their posterior that hurt like hell. Stop immediately and switch to oral progesterone. It's not as good, but the immune inflammation that is caused by you having those giant pink welts is way worse than the decrease in your efficacy from the progesterone. So stop if you're getting the giant allergic reaction kind of pink welt. It won't work out well for you. Yeah, we did that today on one of our patients, actually. Yeah.
That's a good question.
We're good?
Almost a joke at this point today.
There's a million?
Millions.
Really?
Oh,
Any other really good ones? Do you want to screenshot them and I'll try and answer them?
yeah, sure.
I might have some time on Thursday to do that.
I got one more for you.
Okay.
One
All
more.
right. One more. Tarek's terminal question. Here we go.
Yeah.
Okay.
I can't answer it, so I got to give it to the pro here.
Okay.
How do you know if you have deep, I did that, or superficial endo? I asked that?
No,
No, I didn't. Okay.
you can't. You got to do.
She said she had stage 4 endo and had ablation done, but my endo pain never stopped. Wondering if I have a deep endo and need excision instead.
Well, if you have stage 4, you have probably got deep infiltrating endometriosis somewhere on you. And if you have DIE, yes, that does require excisional therapy. You can't just ablate DIE. So yeah, those are cases where it has to be removed. Yeah. But there's no way you would know it ahead of time. MRI might show you if you have an expert that knows how to read an endo scan. Most of the radiologists, they're not trained for that. So it kind of takes specialist radiology training.
When are you going to open your office in Toronto, they asked?
I don't know. I'm busy opening up an office near Toronto. And then I just got called by another gentleman who wants to open an office with us not too far from us here. So I am busy. I will get to Toronto as soon as I can. I kind of started something in Toronto, but it didn't quite pan out because the people I was trying to start it with just weren't kind of philosophically aligned the same way I am. So I'll have to try again, but we'll figure something out. Yeah. I was hoping actually the former clinic I worked at would someday decide to sell, and I would buy the funding and then start a separate clinic somewhere using their funding, but that hasn't come to be, so nor do I think it ever will. I think we're good. Are we good? I still have to do a consult after this, you know that?
Hey, you're done when you're
We
done.
still have millions?
Yeah, you're not getting through it. Even if you gave it an extra 5 minutes,
It's still not getting through it. Well, listen, thank you all for your interest and your questions. We will screenshot your questions, screenshot before we shut down so that it's there. And then I'll answer them separately, either in private or I will do a whole bunch of little mini videos. So I hope you guys have a great week. Wish me luck in Italy. And I will be going from Italy to my daughter Jenna's graduation. So lots of thumbs up for little Jay. Jay, we love you. We're very proud of you. And you better be packed when I get there so that I don't have to pack everything for you, you monkey. I love you, and I love all of you guys too. So have a great night from Tarek and Rahi. Take care, guys. Fertility Factor Fiction. Click that like button and make sure you subscribe and follow us on YouTube and Instagram. Our YouTube, by the way, is blown up recently. Next week, no show. Tarek says next week, no show. So I won't be here next week, but the week after we will be back. Maybe we'll do like an hour and a half show that next week when we come back.
Oh, okay.
You're okay with that?
Yeah.
We'll have to eat a little extra food.
Oh, if we can.
We'll have a little intermission.
Yeah, maybe that's what we need, intermission.
All right, guys, take care. Have a great night.